So next we have Angela, I believe. So Angela Chen is a PGY3. Thank you. Thank you. Wonderful. Angela was also a medical student here. We're so happy to have kept her. She's a wonderful resident. And she has the best presentation name called I Am the Closer.
Hi, I'm Angela. I'm one of the current second-year ophthalmology residents. The title of my presentation is I Am the Closer, and thank you to Dr. Soy for this case. Our case is of a 66-year-old male who presented to the VA with progressive vision decline in the left eye since 2017. His past ocular history was notable for traumatic angle recession glaucoma in the left eye, diagnosed in the setting of a grenade explosion in 1981, as well as having a diagnosis of ocular hypertension, glaucoma suspect in the right eye. He was being treated with IOP lowering eye drops and underwent SLT in the right eye in 2021. He had a refractive error, but since then has had cataract surgery in both eyes in 2022. His very first visit to the VA that's available in our EMR was in 2004. And at that time, his visual acuity was 20/25 in both eyes. His pressure was 23 in the left eye, so a little elevated. And then on gonioscopy, he had angle recession in 3 quadrants. Otherwise, his anterior and posterior exams were largely unremarkable. Fast forward 15 years, now his visual acuity in the left eye has dropped 1 to 2 lines. His pressure is well controlled with his medications. And then on exam, now he has a bit of a cataract in both eyes, perhaps a little bit more significant in the left, and a possible lamellar hole. So his OCT MAC at that point showed a lamellar hole, and the discussion with the patient was that the drop in his visual acuity by 1 line was likely attributable to the cataract and unlikely to be attributed to the lamellar hole. But even though he got his cataract surgeries done in 2022, he still continued to experience progressive decline in his vision in the left eye. So now he was 2200 in 2023, and at this point we can see that he has a full thickness macular hole, re-demonstrated again 1 month later. So now we have this discussion with the patient regarding surgery. The risks, benefits, alternatives were discussed with him, and he ultimately proceeded with a vitrectomy, membrane peel, ILM peel, endolaser, and gas fill with C3F8 in the left eye in May. So after his initial retina surgery, we can see at post-op week 2, the full thickness macular hole is a little smaller, but still persistent. And then at post-op month 1, it's becoming a little larger again. We can see some edema at the edges. So we had another discussion with the patient about undergoing a repeat retina surgery, and he was agreeable. He underwent repeat vitrectomy, membrane peel, and additional gas fill in the left eye in June of that year. This is his post-op course from the second retina surgery, and basically he still has a persistent full thickness macular hole. So week 1, week 2, all the way up to month 7, we can see that the full thickness macular hole is still present. And at this point, earlier this year, we discussed with the patient the option to undergo another retina surgery, and this time with amniotic membrane transplant. Can you help me play this video? Thank you. So thank you to Dr. Fortes for providing the video. It's not actually of the surgery for this particular patient, but a very similar case. So in that patient, also with a full thickness macular hole that had persisted despite previous retina surgeries, they proceeded with an amniotic membrane graft. Brilliant blue G is used to stain the ILM. There was confirmed to be no more ILM left because it had already been peeled. They placed the chandelier. Here they're preparing the graft. So they take the AMT and they use a dermal punch to actually create the small button, but then they resize it specifically to the size of the macular hole. And positioning it is important. So you want to position it with the chorion layer facing downwards toward the RPE. I can hear Dr. Soy whispering in the audience that it's really hard. The question is, how do you know which side to put down? Is it stickier on the chorion side? Mm-hmm. It could invert. So just for the folks on Zoom, Dr. Soy is saying to help with identifying the correct side, you can sometimes visualize the microvilli, and then in their preparation of the graph, sometimes they'll mark it too. He's using a flex loop now to insert the graft in place, and we have successful placement with overlap of the retina above the AMT margins. Great job, Dr. Fortes. And then we fill with SF6. So this is his OCT MAC from the initial post-op course after the AMT surgery. At post-op week 1, we see that his AMT is well positioned. The retina isn't completely connected over the AMT yet, but it's well opposed at least to the membrane, and that's redemonstrated again at post-op week 2, post-op month 1. And we already see that there's some improvement in the visual acuity, so he pinholes to 20/80 in March. At his most recent visit, which was a week ago, his vision pinholed to 20/80 in that eye, and he is still demonstrating good apposition of the retina to the AMT, and it probably is starting to connect. The picture on the right-hand side is just the wide field fundus photo showing good placement of the AMT. So I'll take a moment just to review macular holes, which are retinal holes involving the macula and more frequently involving the fovea. Risk factors include higher age, female gender, high myopia, trauma, and ocular inflammation. And the pathophysiology is thought to be associated with vitreoretinal traction of the posterior hyaloid on the parafovea. There are different ways to classify macular holes. So the gas classification system stages based on the evolution of the macular hole, no hole, and then the holes delineated by size. In this case, the International Vitreomacular Traction Study classification system is now commonly used. So it delineates it based on vitreomacular adhesion, which is when there's no distortion of the foveal contour. So panels A through B, they just show a focal versus broad vitreomacular adhesion. And then in C, there's concomitant wet AMD, but there's no distortion to the foveal contour. Vitreomacular traction refers to when there is distortion of the foveal contour or intraretinal structural changes. And then finally, full thickness macular hole is when there's a defect all the way from ILM to RPE. Ways to manage macular holes include medical therapy. Intravitreal ochraplasmin is a serine protease that induces vitreolysis and can separate the hyaloid from the underlying retina. But in 2020, it was taken off the market because it wasn't very popular or effective. And then some people have also tried to use intravitreal gas or air. In terms of surgical therapy, the mainstay of treatment is vitrectomy with membrane peel, ILM peel, and gas. And this is effective in closing upwards of 90% of macular holes. So most macular holes can be successfully closed. In some cases, surgeons might like to use inverted ILM flaps. The thought is that when you invert the ILM flap, the Mueller cells can proliferate and induce gliosis to then fill the macular hole. This can be used in large idiopathic macular holes and secondary macular holes, including myopic ones. But there are certain cases where you might have limited ILM, maybe they've already been peeled before, and in those cases, you might consider autologous retinal grafts, amniotic membranes, or distal ILM flaps. Risk factors for persistent macular hole after surgery include larger size, increased time to repair, so greater success is achieved when it's within 1 year after onset of symptoms, high myopia, retinoschisis, ERM, and history of trauma. Amniotic membranes have been used in ocular surface disease as biological scaffolding for conjunctival growth. And more recently, studies have shown that AMT put into the subretinal space can also help to close holes by stimulating tissue proliferation and retinal hole closure. So in one study in 2018 by Rizzo and colleagues, they were able to successfully fill all 8 macular holes with AMT and then achieve closure in 100% of the cases. The advantages of subretinal AMT include them being commercially available, thick, and easy to handle. They can be used in patients who don't have a cataract. They can be used in patients who've already undergone cataract surgery. And certainly in, like we've mentioned before, in those patients who don't have as much ILM for peeling. Complications include retinal detachment, subretinal hemorrhage, RPE atrophy. The hole could get bigger. And then in terms of graft preparation, it could be inverted, it could be undersized, and then afterwards it can contract or dislocate. There's been one documented case of high IOP. In this study with multidimensional imaging from 36 patients who underwent macular hole closure after having already failed vitrectomy and ILM peel, what we can see on the right-hand side, so panels D through F, there's good placement of the AMT, the outer layers of the retina are starting to close over it, and then there's reduction in the foveal avascular zone and good quality to the superficial and deep capillary plexus. The wide field fundus photo at the bottom resembles ours, namely that the AMT is well positioned in the macula. Other studies have gone on to show the good success rate of macular hole closure after AMT. So in this one study of 22 patients, the closure rate was 91%. They didn't find a statistically significant visual acuity change overall, but I think that largely depends on the preoperative characteristics. So it's been shown that maybe the visual acuity won't get that much better if they've had a chronic macular hole, for example, or if they've had high myopia. And at least in this study, the complication rates were also relatively low for subretinal silicone oil, choroidal neovascularization, atrophy, and CME. In this meta-analysis by Zhang and colleagues, they once again, after studying 8 different cases, found that the macular hole closure rate with AMT graft was successful at upwards of 90%. In this study, they compiled the different results and they found that the visual acuity improvement rate was 66%. Graft dislocation and contracture rate was only observed in 6% of cases. No intraocular inflammation was found. And then they made a comment that cryopreserved grafts may have better outcomes than dehydrated grafts, just because they're less likely to contract. In summary, the rate of macular hole closure is generally high with primary vitrectomy, membrane peel, ILM peel, and gas. However, larger holes, chronic holes, and reoperations are very difficult to close without many good options. One viable option is amniotic membrane transplant, which we've demonstrated in this case.
Thank you, Angela.
Thank you, Dr. Sway.
Thank you.
And Dr. Fortes and the
job.
VA, which is a
job.
great place for us to learn as residents.
Thank you. It's like I paid you guys to say that or something. Question for the audience. How many people have heard of this as an option, AMT transplant for macular holes, before today's presentation? So some people, okay, maybe 30%. So like Angela said, good thing is most macular holes close with one surgery and gas with face down. But it is frustrating when they don't close. Each subsequent surgery, I feel like the chance of it closing is even less. And I do feel obligated when they don't close after one time to offer them a second surgery. So I think this is a great option for those rare cases that don't close. This is pretty good. I feel pretty good about the chance of it working and not having a bad side effect. I also want to just credit Blake for bringing it to me. He did his research. He presented the data to me. He found the ideal patient and I staffed him on the first case and it went very well. And we've since done 3. Again, these aren't very common, but we've had 3 in the short, less than a year that he's been here and they've all done well. Also, like Angela said, the sizing of the graft is key because if it's too small, then it doesn't really work. And what might not have been clear is our key, I think, is also using the flex loop to tuck it under because otherwise to detach that area is tricky and there's complications. But it looked, you could almost not even see what he was doing is you just slowly have to tuck it in 360 and that is the key. Also, the first few times that we tried, we kept on cutting it. He didn't show that, but we cut it too small, too big. Good thing you get a lot of amniotic membrane in one graft. And so it went well and it's going well. Thank you, Angela.
Thank you.
Any questions or comments from the audience? Yes, Dr. Deemer.
Anatomically, this is amazing and technically impressive, but it seems to me that in a way, the best outcome is like having a subfoveal disciform scar, a little one, right?
Maybe. Well, so of our 3 patients, the vision didn't change in the other 2. And we tell the patients that because these are chronic, because these didn't close the first time, there's RP atrophy underneath, because, well, so it is like a white piece of tissue, but over time it does thin. So I think it's not exactly like a disciform scar, but you are right in that we don't know what the visual outcomes are in these patients, and we're not sure how to counsel patients. So we do tell them that the chance of anatomically closing the hole is pretty good, but whether the vision changes or not, we're not sure yet.
But the photoreceptors are not in continuity with RPE directly under the graft. Am I correct?
You are correct. The retina is on top of the graft.
Thank you.
Thank you. It's a great question. Okay, next, Junru's up next. Junru Yan, she's also, yes, better go. Yeah. You mean like drawing the patient's blood, spinning it down? Hmm. Okay, so Federico's question, I believe, is using commercial product or the patient's blood with fibroblast growth factors to put a drop and close the hole. So I don't have much experience with that. The one thing I will say is when I was a resident, Stanley Cheng, who is a great mentor to me, he was doing that. And I believe he had good outcomes. I don't think it has caught on widely, which I don't know, makes me wonder if it's either that technically feasible or the great outcomes. I don't know too much about it besides that. Do we have a comment from Zoom? A question?
We do. Thank you. Thank you. It's Abdish Bhavsar. I can make a brief comment on the prior surgical technique, but very nice presentation and covered a nice range of topics on terms of closing holes that are not primarily closed. And there's one other technique that deserves mention and has been published by others. I published it as well, and I've also written it in a book chapter that is in our retina surgery textbook. The method of very gentle focal laser with a gas fluid exchange offers a non-surgical, non-return to the operating room option for closing macular holes. And it's something that has been talked about for many, many years, initially presented by others many years ago, but it remains a topic. I think that most of us tend to go back to the operating room if we have a closed hole, but this offers another chance to look at non-surgical options. So I think it's worth it to consider. The question about using autologous serum and serum that we spun down, we had done that many, many years ago. That technique is now, I would consider, an outdated technique and no longer needed and no longer necessary. But we all did it many, many years ago, and it's fallen out of favor since that time. Thank you.
Thank you. Thank you for good. It's good to see you.
I don't think there's a bigger skeptic in the whole world about amniotic membrane than I am. I'm just not convinced it does anything at all. But if it does anything for epithelial healing, people have argued that it's because it is a good stimulates. It stimulates the basement membrane and has chemical factors that maybe make the fibroblasts in the skin more enthusiastic to close a wound. But I'm not sure how either of those factors would work in the retina. And if there's something in the membrane that's some humoral factor that's helping, it seems like you could isolate that and then just inject it in the eye.
Thank you for your comment, Bob. I will say that this patient noticed improvement in vision, whether it's psychological, I don't know, but he also measures a few lines better. I do agree with you, vision-wise, I'm not sure yet if it's making a big difference. Thank you. Okay, good discussion. Junior, take it away.
Hi, everyone. My name is June Rue. I'm like Angela. I'm one of the second-year ophthalmology residents. Today, my presentation is titled Dry Eye, the Good Kind. I have no disclosures. Our 81-year-old gentleman presents to the VA for cataract evaluation for his left eye. He's a known glaucoma suspect, had recent successful surgery of his right eye, no past medical history or no significant past medical history. And his exam at his pre-op visit, vision was 2200, pinhole 2070, normal IOP, normal anterior posterior exam, aside from his dense brunescent 3+ NS cataract. Unfortunately, his cataract surgery of the left eye was complicated by zonular dehiscence, posterior capsular rupture, and necessitating a placement of a sulcus IOL. Post-op day 1, he's actually doing quite well. His P pinholes to 2040. His IOP was a little bit elevated, treated appropriately. Post-op month 1, he's doing very well. Vision is 2040. IOP is normal, and his posterior exam is normal. Post-op month 2, however, our patient unfortunately had another complication. He had an IOL dislocation, found to have anterior inflammation and macular edema. The decision was made at this point to proceed with a vitrectomy and IOL exchange with ACIOL placement. Unfortunately, after he had the surgery, he had persistent and progressively worsening macular edema with no improvement on topical prednisolone, ketorolac. He was also found to be a steroid responder, so the prednisolone had to be stopped. At month 6, unfortunately, we decided to try Eylea injection given his worsening edema. However, the edema worsened after a month, so we did not pursue further anti-VEGF treatments. At month 8, this is what he looked like. His vision was count fingers, pressure was okay. And at this point, the decision was made to trial Xipere, which is suprachoroidal injection of triamcinolone, 4 mg per 0.1 mil. This decision was made due to his intolerance of topical therapy, steroid therapy, lack of response to anti-VEGF, and contraindication to Ozurdex placement given his ACIOL. So again, this is his picture at day 1, a day of injection. Post-op week 1, he has an amazing response. He's 20/70, his pressure is still fine, and his central subfield thickness has almost improved by 50%. Post-op week 5, we continue to note improvement. You can ignore the central subfield thickness, the lines are drawn incorrectly, but his vision is still pretty good. Week 14, he's 20/30, and we continue to note improvement, no subretinal fluid at this point. And post-op week 26, which is month 6, he's doing very well still. Vision is 20/40, and his central subfield thickness is down to 300, decreased from 885 where we started. Throughout this whole time, our patient, despite being a known steroid responder, his IOP has been normal this entire time. As an overview of our existing therapies, we have topical treatments such as NSAIDs and steroids, There we go. So topical therapies for our patient were ineffective. And there's also periocular options such as subtenon triamcinolone, but the POINT trial in 2019 showed that the periocular triamcinolone is not as effective as intravitreal triamcinolone or Ozurdex at resolving macular edema or improving vision, and can still induce an IOP elevation given that he is a steroid responder. Intravitreal options can be considered. We did trial Eylea, did not do anything, and could consider intravitreal triamcinolone, but he does have this history as a steroid responder, and Ozurdex for our patient was contraindicated. So what is Xipere? Xipere is a drug that was approved in 2021 for macular edema associated with non-infectious uveitis. It's a suprachoroidal triamcinolone injection. And the idea is that it isolates the corticosteroid distribution to the posterior segment with minimal anterior segment concentrations. So the hope is that we gain all the benefits of the posterior segment while avoiding all the problems in the anterior segment, things like elevated IOP, cataract formation, and also avoid the risk of implant migration. The Peachtree trial was the phase 3 drug trial done for this medication. It involved 160 non-infectious uveitis patients, not categorized based on specific diagnoses, just categorized based on anatomic distribution of their uveitis. So it's pretty much split quarter between anterior, intermediate, posterior, and pan uveitis. And the patients were split 3-2 to receive suprachoroidal triamcinolone versus sham at day 0 and month 3. They were injected at these 2 time points, regardless of whether there was recurrent fluid in the macula. Eyes that were excluded were patients who had eye infections or intraocular pressures greater than 22 at starting point. So at week 8, in the first chart, you can note that 49% of the patients who received Xipere attained vision of 20/40 versus only 15% of patients in the control group, with concomitant noted decrease in their central subfield thickness. And this was maintained and statistically significant at all time points moving from week 8 to week 24. Only 13.5% of the patients in the treatment group needed rescue therapy versus 72% in the control group. Rescue therapy being deemed as patients who had like worsening vision, increased macular edema, or based on the physician's discretion. And the treatment for rescue was not specified. It was just based on whatever the investigator felt was necessary. Of note, only 11.5% of the patients had increased intraocular pressure in the treatment group, whereas more like 27% of the patients receiving intravitreal or periocular corticosteroid in the rescue group experienced an increase in their IOP. The Magnolia trial was the extended efficacy and safety study extending an additional 24 weeks beyond the Peachtree trial. 33 patients were enrolled, and all the patients that were enrolled were considered eligible because they completed the Peachtree trial without necessitating additional rescue therapy. And the primary endpoint for this study was time to rescue. And here we see that 50% of the patients were able to maintain their effect from the injection up to 9 months after suprachoroidal injection in this study. And only 14.3% of the patients experienced an IOP greater than 10, compared to 26% of patients who received intravitreal triamcinolone in the POINT study in 2019 that we mentioned earlier. So circling back to our patient, this is the first case to our knowledge for suprachoroidal triamcinolone helping with a refractory postoperative CME after cataract surgery. The Peachtree and Magnolia trials did not explicitly separate out diagnoses for specific types of uveitis aside from the anatomic designation. So our patient here demonstrated rapid and successful reduction in macular edema even at week 1, which is something that's very exciting because the Peachtree trial didn't start monitoring patients until month 1, and we can see that patients can experience an improvement in their vision as early as week 1. We also saw in our patient, who was a known steroid responder, that he had normal intraocular pressures throughout this whole time, which is really exciting because a lot of the patients, this expands the number of patients that we can potentially give this to help their conditions while potentially not worrying about having a steroid response. And also for this particular patient, he has not had recurrent edema after a single injection for 6 months. The Peachtree trial, once again, they injected patients at time 0 and month 3, regardless of whether there was recurrent edema. So potentially, we can subject patients to fewer injections with this type of medication, And just as, total transparency, our patient actually came back early last month, early April, with a little bit of edema, but then he came back at the end of the month and the edema went away without doing anything. So count that as a win. So thank you so much to Dr. Sway, Dr. Edmund Choi, Dr. Shani Pilar, and of course our medical student, Justin Hansen, who's writing this case up, and of course our patient and the VA, because we love working at the VA and the VA is great.
Thank you, General. Thank you. Okay, so I am a big fan of this steroid option. I think the risks are less than intravitreal, and I think the efficacy is better than a sub-Tenon's. So I've been using this more and more. This was the first patient that I used it on. Getting it in the eye is a little bit tricky at first. I believe this was in August or September, and we had it at the VA first. Since then, it's now available at Stein. I've used it on probably a dozen patients here and maybe 6-ish at the VA. And it had good experience. Does Edmund have anything to say? I think most of my patients come from him. He is referring the uveitis patients for this.
Yeah, this is a great case and a really good use of the off-label use for Xipere here. So the patients that you injected, some of them had vasculitis, which actually responded quite well. Irina and I are writing a case series about pediatric patients who had underwent Xipere injections because, for kids, we're concerned about seroresponse, cataract development. So possibly this could be a better treatment, more well-tolerated with less adverse effects for certain types of uveitis. The FDA label is for uveitic macular edema. So these are off-label indications or off-label diagnoses that we're using it for. But hopefully they can maybe expand indication of the label in the future.
You know, one thing that I don't know if you can answer now or you have to see it, but I had Justin pull a PDF and I wanted to show you that the company lists macular edema after cataract surgery as an ICD-9 code
Mhm.
to put for reimbursement. I don't know if that means it's one of the FDA approved indications, but they are advising us to use certain codes.
Huh. Yeah, I mean-
So we'll show you and see, because when we write it up, we want to make sure we say correctly if it is FDA approved. Yeah, I was going to ask Abhish if you had anything to say. Go ahead.
Oh, thank you so much. It's Abdish Bhavsar. I think I have one of the most vast experiences in using Xipere in the upper Midwest, and it is a tremendous advantage to add to our armamentarium for battling uveitic macular edema. It's amazing. Some of the folks have suppression of macular edema and inflammation for 9 months or a year, or I've even had a few patients who have been refractory to every single treatment that we've done. Some have responded to triescents when we had triescents, but in the absence of triescents, had injections, needing injections every couple of months, and now have been quiescent for 6, 9, 12, 18 months. That is remarkable. And we just haven't seen that before in a drug administered like this. So I think it's tremendous, and it's just a huge advantage to be able to use it. So thank you for presenting it.
Thank you for your input. And I want to say, without saying the name, there have been other long-term steroid injections that were marketed to last up to 3 years, and they haven't. I have been not impressed with them at all. And Abish, I just want to say before you are gone, it's hilarious. You don't know what the room looks like, but when you turn on your camera, your face is like 100 times bigger than anyone else's face.
Oh,
and it
sorry.
pops in the middle of the auditorium.
I,
And we love
I
having-
apologize for my face in advance. Sorry about that.
It's awesome. Like very,
Thank you.
there he is. Yeah, we like that.
Thank
Yeah.
Yes,
Sorry about that.
Looks like that of the wizard in The Wizard of
Yeah,
Oz.
there's something very dramatic about when he comes in the room. Yeah.
Sorry.
The prospects for this use of this in inflammatory disease and in children with uveitis are quite impressive to me also. Could you elaborate a little bit on the technique, how you do it, where you do it, how technically difficult is it to give this suprachoroidal injection?
This could take a long time, but in brief, you go perpendicular. They have 2 different needle sizes. I was using the longer one first, but now it's recommended you start with the shorter one, and if you can't get it, then you switch to the longer one. So it's a 30 gauge, it's very short, you go straight in, and the tricky part is you're opening up the space. So you have, if you're not in the right space, you can't push, nothing will happen. So one hand has to kind of readjust and twist and turn while the other one is pushing down on the plunger, and it's a feel of how hard to push and when you get it. And then you just freeze the twisting hand when the plunger is moving and it goes in. I had the rep there the first couple times to kind of walk me through it and just encouraging me. I felt good after like number 5 and 6, and then number 10, I had trouble again. So I think I don't know when I'm going to feel completely comfortable, but I feel more and more comfortable. And I might also say proudly that I think I've gotten everyone in, even one at the VA that was somewhat traumatic and all the residents were watching. And I didn't know if I got it in, but he came back post-op week 1 to do it again. And with a partial dose, he was flat. He had huge macular edema, and just with a little bit, it was fine. I don't know if that answers your question. So it takes some time, but I think once you get it, then you get it. Abish, you're back.
Yeah, I would just add that anyone can learn how to do it. It's a difficult technique to learn because we've never, unless you've been specifically trained to do it, for example, in the Aura trials, we were doing suprachoroidal administration, but if you've never done it, it's very difficult. However, everyone can learn to do it, but I would encourage you to get a model eye and do it on a model eye first. Learning the feel, it's amazing how good the model eye is that they have. It tells you exactly what it feels like to try to inject when you're not in the suprachoroidal space and you get all this resistance, and then all of a sudden you are in the suprachoroidal space. And they have differing variable insertion resistances to give you an idea of what it really feels like in real life. And it's a tremendous tool to use. So the model is really, really key. And it is rough. Your first few, you really are sweating because you can go into the eye with it too. And so you do have to be careful, but it takes a lot of pressure on the eye to end up in the suprachoroidal space. And that perpendicular that you mentioned is so critical, because if it's not perpendicular, it doesn't get in the right space and it doesn't go in the eye. Thank you.
Thank you. Thank you. We'll move on. Yeah.